Once patients relapse after primary therapy, usually based on prior clinical trials and prior drugs that were available, their responses were short-lived, and unfortunately mortality was much closer. However, with the newer drugs, so the Ibrutinib, idelalisib, rituximab, or venetoclax options, which are all FDA approved for relapsed refractory CLL, there's much less emphasis on these prognostic factors being criteria under which they would not be able to receive those drugs. So while it's very important to know these parameters, it means less to a practitioner if I wanted to use Ibrutinib, or if I wanted to use venetoclax, or I wanted to use idel or ritux combinations. Even if they had adverse prognostic factors, I would feel okay treating them. However, they still do play a role, and I'll give a specific example. So if a patient was relapsed and had now 17P in a FISH panel, they would respond to these novel agents very, very nicely, particularly Ibrutinib or idelalisib rituximab, but their responses would be less robust than if they didn't have that particular FISH defect. To be specific, I believe the current data for patients getting Ibrutinib who have 17P is around 26 months progression-free, whereas for the more favorable risk groups, that is 13q or trisomy 12, or even having no abnormalities, the progression-free has not been reached. So while it's great, there's definitely an improvement over prior drugs. Having that particular genetic defect would suggest to me that they won't respond as long.